Hello, everyone. Welcome. Glad to see so many people joining for this masterclass of today. So first thing first, for practical reasons, this recording will be shared after the session, the slides as well. And at the end of the presentation of Professor Demedts, we will also do a Q&A. So why are we here? Well, early 2017, our CEO and Professor Demedts met, and together with his team of doctors, nurses, nutritionists, psychologists, and social workers, Professor Demedts had a vision for a more multidisciplinary lung cancer care that was focused on outcomes while keeping an eye on efficiency and the costs to realize those outcomes. And they choose to implement this vision together with Abel in the form of an integrated digital lung cancer pathway, which went live later that year. And in November last year, the results of this vision were published in the Lung Cancer Journal, and the results showcased that the care pathway results, and yes, this is a spoiler alert, but it resulted in longer survival, fewer emergency room visits, and reduced length of stay in the day clinic. So the transition here was they improved outcomes at a lower cost. And I think, and the team at Able as well, we truly believe that Professor Demedts and his team are a true example of value-based healthcare in practice. And we couldn't be more proud of this collaboration. And we're really happy that we are hosting him today to share his best practices and lessons learned. So the floor is yours, Professor.
Okay. Hello, everyone. I hope you can see my screen and can hear me. If not, Rick, give me a sign out.
Yes, we can.
Okay. So I'm Ingel Demedts. I'm working in as at Delta Hospital in Roeselaar in Belgium, a pulmonary physician with a special interest in thoracic oncology. I'm just trying to go to the next slide. Okay, here are my disclosures. Just as the background on how we started on our digital care pathway, we have to go back to like 2016 when we received, as every hospital did at the time in Belgium, from the official instance report on our outcomes for our lung cancer patients that was compared to the outcomes in other hospitals. When I say outcome, actually it was just on survival, so the mortality of lung cancer patients. And we were quite happy because we did very well. We ranked in the top 3 for Belgium, and we had a very good 1-year survival for metastatic lung cancer patients. But still, we didn't feel quite satisfied with this because was this actually the case? You get a report like that every 2 or 3 years. You have very few information on the population you are comparing, so maybe there's a lot of bias. So we're not really happy with those kind of reports. So we wanted to look a bit further. First of all, we only had an idea of quantity of life, survival, but no information on the quality of life of our patients, very important in metastatic lung cancer. We didn't have any idea on which quality indicators to measure if you wanted to measure quality, and there was no systematic outcomes measurement in place. Having said that, that was in the time of chemotherapy. We knew that lots of our patients, despite the good results, suffered of quite some side effects from treatment. We did a little analysis on that back in those days, and a lot of side effects were reported by the patient themselves. At the same time, and I'm at the bottom left now from the slide, we wanted to do something more about the patient empowerment. So there was lots of things to do coming on in those days, and now even more about patient empowerment, trying to give the patient more his own voice in the care process, which is not that easy. Trying to use patient-reported outcomes, that was another issue we were dealing with at that time. And then fourth, at the bottom right of the slide, we were struggling for a while to use early supportive and palliative care earlier on in the care process. So we know since like 2010 was a paper in New England Journal of Medicine demonstrating that early palliative care for lung cancer patients increases the survival. So if you address this issue early on, you can increase survival. It's not that easy to establish that in daily clinical practice. So that was the fourth thing we had some worries about around that time. And then finally, we also sat down with GPs in our region about how they were thinking about our care for lung cancer patients. And what they mentioned is that they were, from diagnosis on, they were no longer involved. They lost the patient, let's say, to the hospital. But sadly enough, most lung cancer patients, and that is what you see in the graph, they go bad. In the end, they go bad and they die very often quite rapid. I mean, within a year or two. And in the beginning, when the diagnosis is established, the hospital team is there with lots of specialists, specialist care from the oncologic nurses, psychologists, nutritional specialists. But then in the end, when patient is going really bad, then the GP has to come up again, but he has no idea or of not a good idea of what has happened in between. So their comment was, we want to be more involved from early on, from and during the treatment, and not only in the end when things are going really bad. That was a fifth thing we wanted to take into account and to try to get better. Yeah. Now, about that same time, because I mentioned we wanted to do something about patient-reported outcomes, we didn't want to do it just like that. There were some reasons for that. So at an ASCO conference in 2016, it was published a year later, Ethan Bash published a study, which you see on the left, that demonstrated that when you use digital monitoring of patient-reported outcomes, so that means during therapy, and that is chemotherapy in this study, for all cancer types. So if you use digital monitoring, weekly assessing symptoms of patients live longer than when you don't do it. At the same time, around the same time, a European trial from France, specifically for lung cancer patients. So that's at the right. At the left is all cancer types. At the right is lung cancer. They explored the value of digital monitoring in the follow-up. So what you see, patients have been treated with chemotherapy. They stopped the treatment, and in one arm, they did a digital follow-up with reporting of symptoms, and the other arm was just a control arm with standardized consultations and chest CT scans. And they also showed that when using digital monitoring of symptoms, patients lived longer than when you didn't do that. So with those incentives or those data in mind, we developed or tried to develop a transmural care pathway for our lung cancer patients, in which we tried to address all the issues I just discussed. So this is the background of how we started. What were the aims of our digital pathway? Well, we wanted to improve the quality of life, so not just the quantity, but also the quality of life. But to be able to improve, you first have to measure the quality of life. We want a better involvement of our patients by the use of patient-reported outcomes measurements. We wanted to involve the GPs early on in the care pathway, so from diagnosis and start from therapy, as I said, not just at the end. We wanted to try to have a better and earlier detection of side effects from treatment, and to optimize the supportive care and the introduction of end-of-life care. So briefly said, we wanted to improve the outcomes for our patients. So if you want to do that, okay, the question is, which outcomes will you measure? You can measure lots of things, but which outcomes are relevant? Taking also into account that at the end of the story, we also want to compare our outcomes to those of interested colleagues. So you want to benchmark. So then it's interesting if you use the same outcomes. Again, we were lucky at about the same time. ICHOM, this is the International Consortium for Health Outcomes Measurements. They published a document in which they proposed a lung cancer standard set on which indicators you should follow if you want to monitor the quality of care for lung cancer patients. It's established by a group of lung cancer specialists, and sometimes patients are involved also. ICHOM develops those kinds of sets, not only for lung cancer, but also for other types of cancer, for IBD, for cataract, and so on. And you can find them on their website. So we use this as a basis to move on. So what do they propose in the ICHOM data set? What you see here is the pathway of a patient with early stage lung cancer, starting at the left. So ICHOM proposes that at the beginning, at diagnosis, and this is the red dot here, you collect some case mix variables. This is very important if you want to compare to other colleagues, to know which kind of population are we looking at. This means tumor type, comorbidity, performance status of the patients, educational level, smoking habits, those kinds of things. So those are collected at baseline, and at baseline you also collect patient-reported outcomes. I come back to this on the next slide. Then surgery or radiotherapy, and then they propose to collect PROMS at 3 months, at 6 months, and at 1 year, and then every year for the time being. Of course, the majority of our patients are not early stage with advanced disease, but the idea is the same. At baseline, you collect case mix variables, information on the biopsy, and then at regular times, you collect PROMS at baseline, 3 months, 6 months, and 1 year, and then after that, every year. So this is the document which we based our care pathway on. But just to say that the ICHOM proposes PROMS every 3 months, but for a metastatic lung cancer patient, a lot of things can happen in 3 months. So when we implemented the care pathway, we used the same PROMS as ICHOM proposed, but at a higher frequency. We do it every 6 weeks during treatment. So on the left, you see the PROMS that are proposed by ICHOM. They propose to use 2 EORTC questionnaires, the QLQ-C30, which is a general cancer questionnaire, and the QLQ-LC13, which is specific for lung cancer. As mentioned, they say at 3, 6, and 12 months, but we do it every 6 weeks. And on top of that, we added a weekly questionnaire. So we do every 6 weeks a general quality of life questionnaire, EORTC. But during treatment, when patients receive treatment that can cause side effects, we monitor the symptoms by a weekly digitally monitoring system in which we implemented feedback loops, and I'll show you that in a minute. Just to show you, this is a Dutch version of the QLQ-C30, but you have it in other languages too. This is how it looks like on paper. We have a digital version now, 30 questions on certain side effects or quality of life aspects for a patient. This is the LC13. For those of you who don't speak Dutch, questions like, do you cough? Did you cough up blood? Were you short of breath? And so forth and so on. And then patient scores from 1 to 4, not at all, or very bad had a symptom. For your interest, the LC13 has now been upgraded to LC29. So this means 29 questions. So important, LC30, 30 questions, 29 questions, lots of questions. So we didn't want to do that every week, but we do it every 6 weeks. And then for the weekly monitoring of side effects, at the beginning, we just experimented with an own questionnaire we put together and with an own scoring system. But then we realized, as I mentioned in the beginning, if you want to benchmark with other colleagues, we should try to use a kind of a standard system. And we used the PRO-CTC AE, which is also used by Ethan Bush in the States, the godfather of PROMS. Maybe some of you know the CTC AE. That's a toxicity scale that is used in clinical trials for monitoring side effects or adverse events from treatment. But then it's the physician who scores that. And in the PRO-CTC AE, it's the patient reported outcome version of that. So it's really the patient itself that reports his symptoms. And this is the weekly questionnaires we use. This is how the PRO-CTC looks like. You can also find it on the internet. Actually, it's kind of a library in which you have almost 80 different toxicities, let's say. It can go from shortness of breath, coughing, nausea, vomiting, lots of things, like almost 80 items. And for every item, there's 1 or 3 questions that they ask for, like the frequency, how much do you have that problem, the grade, how bad is it, and then the grade in which it interferes with your daily activity. Of course, we don't ask all those things to our patients every week. We just made a selection based on the most common side effects of our treatment from a little more than 10 questions out of this library, just to show you this is where it comes from, and you can find it like that on the internet. This is the Dutch version. Again, you have also in other languages. So you see this every time you question, then the patient reports if he doesn't have at all a problem with it or very much on a scale till 5. How do we use those questionnaires? I mentioned the EORTC questionnaires, big questionnaires, lots of questions, which we do every 6 weeks. Our idea is to use that at the population level to monitor the quality of life from a given population of lung cancer patients. For example, oral stage 4 lung cancer patients on chemotherapy. They have those questionnaires, those are those scores, and you can compare them to your colleagues. The PRO-CTC AE, So the weekly questionnaires, we use them during treatment. If treatment stops, we stop asking them every week. As I mentioned, there are some feedback loops, and those are used really at the individual patient level. We use them in discussions with the patients. We use them in the multidisciplinary team discussions, while the ERTC questionnaires are more population based in our point of view. I mentioned the feedback loops, and this is really a crucial point if you want to use digital prompts, because if you ask patients to fill in huge questionnaires every week and you don't give any feedback, they don't feel that they are used to their answers and nothing is done with them, they will stop filling in the questionnaire. So different feedback loops were created so that the patient feels, and the team also, that it's really of value that they do this. Feedback loop between the patient and the hospital, the GP, and the oncologic coach. And I'll explain that in a bit more detail. So how we do work in practice, what you see here is an intake session where the patient sits down with the oncologic coach in our center. They use a tablet at that time, and they go to the case mix variables that ICHOM proposes to collect. There are two advantages of that. It's kind of a conversation, so the patient and the oncologic coach get to know each other. At the same time, because the onco coach is there with the tablet, the patient is helped. They try to, they get to know the system. They know how to log in. They see how it looks like, and when they are at home, they are already used to it, and there are no or very few technical problems or low compliance issues. And this is how it's looked like on a tablet. This is in Dutch. I just translate for some of you. So the first question here is the educational level. Then the patient reports if he has lost weight. They say their current weight. They self-report comorbidity. So it's not us that's reported. And ICHOM is patient-reported comorbidity, smoking habits. And they go through it together with the nurse, just clicking on those little boxes. So actually, it's the patient health status registration by the patient, but helped by the oncologic nurse. And that's a good starting point. This is how the questionnaire, the ERTC questionnaire, looks like, again in Dutch, but you see it's very simple. Patient just clicks it on. It can be on a tablet, on a smartphone, or on a laptop or PC. Very easy to complete. And this is the QLQ LC13 visually displayed. Then the patient starts with the treatment, and from the moment he has filled in the baseline questionnaire, there's a whole of electronic messages that are set ready to be sent to the patient. So this is how one of those messages looks like. This patient receives an email, so it's email driven. It's not SMS or not texting driven, it's email driven. The patient gets an email in which we ask them to go to their GP to have a blood sample taken, to fill in the questionnaire, and we also have some contact details of the hospital on it. And then they just click in the email and they go to their questionnaires on a web-based platform. Again, weekly, we call it the mini checklist, weekly during treatment, and every 6 weeks the ERTC questionnaires. So this is done now by the patient at home after he has been instructed by the onco coach at the start of therapy. This mini checklist, again, this is what the patient does every week. I mentioned the PRO-TECT, but we also added in the weight. So patients are filling in their weight, if they had fever or not. Then the PRO-TECT question, 10 on the physical aspects of side effects and 3 on more psychological side effects. But then we added some more questions, and I explain you why. On, for example, financial issues or practical issues. For example, patient has a question about oxygen. So if he fills that in, there's an alert going to the social department from our hospital. Or patients have questions about end-of-life care, palliative sedation, pain problems. There's a specific question for that. And if they want to, the palliative nurse gets in touch with them. We ask if they are worried about their partner or family members, and if there are any spiritual or religious issues. This is because we have a spiritual worker in our multidisciplinary team involved. And then we also ask them if they want us to get in touch or not, and I explain you why. So this is how it looks like. Again, same type of visuals, just clicking in the boxes, very easy. Then the additional questions, again, I will translate. On the top, you see, do you worry about financial or practical issues? And if the patient says yes, they get a question that our social department can help them with this, and we ask them if they want an appointment the next time they come in the hospital. And so further on for other questions. At first, we were a little bit afraid because lung cancer patients, the median age in Belgium is ends of 60, almost 70. Not all of them are digitally very active. And we were a bit afraid that the compliance with filling in the questionnaires wouldn't be that high. But in the beginning, we measured that a few times, and actually this was very good. So the compliance at the first questionnaire was 93%. So 93% of the patients responded. If they don't do that, they get an automatic email reminder within 48 hours, and a second again 48 hours later, and then the compliance goes up to 100%. We do not monitor that any longer, but we did that in the beginning. And okay, when we saw that, we saw that we didn't have to worry too much. And that was also actually what was seen in the group of Ethan Bush, and in the French trial, they also had quite high compliance rates. So just going back to the email alerts, if a patient reports a kind of a symptom or fever or he lost weight, there's an automatic email alert to the care team in the hospital at a certain threshold. Important, what I didn't mention yet, we also have multidisciplinary care teams in the hospital every week for our lung cancer patients, where we have the doctors, the thoracic oncologists, but also the oncologic coach, the psychological nurse, the palliative care nurse, the dietist, and so forth. So we sit together every week, and all those team members receive those alerts. In the beginning, we said, okay, we will only, because we were afraid of getting too much emails, we will set the bar. If a patient reports high or very high problems, then you will have to get an alert. But after a while of experimenting, some of the team members said, well, actually, that's not really fair. We ask the patients every week to fill in a questionnaire, but even if a patient reports every week that he has only minor symptoms, it's still a symptom. So we cannot ignore that. And then we said, okay, from the minimal symptoms there are, we will get an alert. But then the email box of the onco coach was like full of emails. He get in touch with the patient, and the patient said, oh, it's not necessary. I just wanted to mention it, but it's not necessary that you contact me. And at that time, we decided to add an additional question where the patient can say, okay, I'd like you to contact me, or it's not necessary, just to have a more titrated way of working, the right care at the right time, and to avoid that our onco coach, who does a really good job here, has too many unnecessary calls. So this process has been changed a few times during the first piloting phase with the system. It's not only the oncological nurse that is involved with the alerts. So we made internal decision rules. And what I mean by that is that depending on the type of symptoms that the patient is reporting, one of the team members gets into action. At the bottom of the slide, you see such an alert. So we get that in our email. You see that the patient had lost more than 2.5% of his weight. He scored high for cough and for pain. If you want to, we can click in the email to go to the care pathway, but the patient said, it's okay, I don't want to be contacted. So this is how it looks like in our mailbox. So what do we do then with those alerts? What are those internal decision rules? Well, we contact the patient if wanted, and mostly that's the onco nurse, oncologic coach, who contacts the patients either by email or by phone, and who makes the first appreciation of the problem. Sometimes he refers the patient to the GP, sometimes he can solve the problem by himself, and sometimes there's a call with us to see what has to be done. If a patient has reported that he feels depressed or he feels anxious, there will be automatically an alert to the psychologist, and then the psychologist will go the next time to the patient when he's on the day clinic. And by doing that, we see that more people are actually helped by the psychologist, because in the past what we did, we said, okay, we have a psychologist in our team, do you want to have a talk with them? And then we quite often get the reaction, no, I'm not mad and that's nothing for me. But in the end, if they are able to at home quite anonymously fill in a little questionnaire, and then they say, I still feel depressed. We noticed that they accept the psychologist next time. It's used by the psychologist, the next time they meet, and then it goes easier on to have a talk and to help the patients. If the patient loses weight or he has to vomit a lot, for example, there's an alert going to the nutritional specialist. If a patient has lots of pain problems, or if he says, I'm worrying about the end of life, I have questions about euthanasia, which is possible in Belgium, then the palliative care nurse will get in touch the next time the patient comes to the daycare. The social service will get in touch when the patient has a problem, financial issues, oxygen, and papers that have to be filled in by us. And every now and then there's a question about spiritual for the spiritual service, mostly religious issues or something like that, and then our co-worker gets in touch with the patient. So depending on the kind of problem that the patient reports, it's a different team member that gets in touch, either immediately or at the next hospital visit, but the central person there is the oncologic coach. Then a little word on the dashboarding. We're still a bit experimenting with that, but if you collect all those prompts, it's sometimes easy to have a visual way of seeing what the patient has mentioned. What you see here is a visual appreciation of the EORTC questionnaires at the different time points. So at the left, there's baseline, and then you see the evolution during time for a given patient. But as said in the beginning, we want to use it to monitor the quality of life at population level, and we're still a bit working on the dashboarding. This is not a final version. At the individual level, we use this. This is kind of a heat map, we call it, of the weekly reported symptoms. So you see all those symptoms at the left of the graph as the start of treatment, and then when time goes on, you go more to the right. But here you can see quite fast which are the actual problems. So you look at the right and you see in red and orange, yeah, those are the problems for the current problems for the patients. But then you can immediately also look back. Has he been reporting that a long time, or is it a new problem? So this is a quite easy, quick view on the actual problems and on the past reported problems from the patients. So we use this heat map when we see the patients or when we prepare a visit of the patient. And then a final feedback loop. So I discussed the feedback loops between the multidisciplinary team and the patient who is at home. But remember, the GPs also wanted to get more involved. So we sat down with them and we asked them, yeah, do you also want to receive those electronic alerts? They didn't want to, and I wasn't surprised, but because we have our care pathway for lung cancer patients, but the cardiologist might have one for heart failure, and there's one for diabetes. And the GPs, if they have to get the emails from all their patients for all those care pathways, they will be at their computer the whole day, and they don't want that, and I think they're right. But what they did say that they wanted is we send the patient a little bit more to the GP than before. Then they wanted to know quite fast if the patient is at their consultation. They wanted to see in their electronic health record what is the problem, what is the patient getting from treatment, and this is what we established. It doesn't matter which kind of electronic health record the GPs use. They can see and that is what you see here, the treatment that the patient is getting. In this case, it's the chemotherapy that the patient gets. They see the last reported PROMS of the patients. For example, they can see in this patient that he was very nauseous and had to vomit a lot. And then there's a little summary on the most frequent side effects that can occur with the given treatment, and some tips, some practical tips for the GPs, what they can do with it. So they have quite fast, they know, okay, I can do this for that problem, and so forth and so on. And then finally also the contact person in the hospital if they want to get in touch with us. And they see that, you know, the GPs in their electronic health records, they see all the reports from all their patients and the hospitals they are sent to, reports from the hospital, blood results, and they can see this report between those results for a given patient. And this is what they actually want. We started in April 2017, and in the beginning, the scope was stage 4 or metastatic lung cancer patients. That's the majority of our patient group, but also the patients with the most of problems, most of side effects. And at that time, we're treated mostly with chemotherapy, again, with lots of side effects. We opted for a digital follow-up and a digital collection of prompts, no paperwork, and we established a system with smartphone, as I said, tablet and a PC. We used the item standard set, as I mentioned, to collect ERTC, quality of life questionnaires, and the PRO-CTC every week. And after the first 40 patients, like a little pilot project, we did a little evaluation because we wanted to know, is this feasible for us as a team? Can we continue like that? What do the patients think of it? We didn't quantify that, but the qualitative appreciation was that patients, the doctors, and the multidisciplinary team at the hospital had a positive evaluation, and then we decided, okay, we go on with this system, we continue, and we use it as standard of care from now on. And so we did, and we expanded it not only to stage 4 lung cancer patients, but to all patients that receive systemic therapy, chemotherapy, immunotherapy, targeted therapy. Is it stage 2 in the adjuvant setting or stage 3 or 4? So it's expanded now, or we propose it to all patients on active treatment. And actually, last year or end of last year, our surgeons and radiotherapists started with an early lung cancer care pathway also. And then in November last year, we published the results of our first 220 patients, different tumor types. You see at the right some demographics, but I go quickly to the outcomes because we were quite happy with that. One of the first things I said, we wanted to detect side effects earlier on. And the idea was, if we monitor a patient every week digitally and we react to the problems reported, we will be able to avoid the bigger issues, the bigger problems, and that might have an impact, for example, on emergency department visits. And actually it was like that. So we saw really 30% less ER visits in patients that are digitally follow-up, compared to those that are in the usual care without digital weekly follow-up. Another beneficial outcome was the time of staying at the oncological day clinic, and I'll explain this first. We come from a system that a patient comes to the day clinic for its treatment, quite often every 3 weeks. Patient came in, blood has to be drawn, the doctor has to come and see the patient, the nurse has to wait for the blood, the nurse has to wait for the doctor, and then the doctor has to wait for the blood result. So you can imagine it takes a lot of time before actually the therapy is started and before the patient can go home. So we change that now a bit, and now what we do now is in advance, we prepare the visits of the patients, and we look at their PROMS and patients we know. So if we see that they have no big issues reported digitally, and if we see that the blood results are okay, so we have a blood sample taken mostly by the GP, sometimes in the hospital. So if that everything is okay, we already give a signal or a sign to the hospital pharmacy to say, okay, tomorrow that patient is coming, you can already prepare the treatment for it. And when patient is coming in the day clinic, they almost immediately can start with their treatment, and that caused a drop in the time of stay at the oncology day clinic with 40% shorter times. And then finally, we also checked on survival. Remember, the French and the American trial I showed demonstrated a positive survival effect. And we had the same. So you see in blue is the survival of patients in the digital care pathway compared to those that are not in the digital care pathway. This is for stage 4 non-small cell lung cancer patients. And you see that those patients that are digitally follow-up live longer than those who are not digitally follow-up. I will immediately say, because before someone says it in the chat, of course, this is a single center experience. This is not a randomized control trial, but there's new and a high grade evidence on the use of EPROMs that confirm our findings and of our colleagues. So Ethan Bush, again, always the same person. In November, there was a digital ASCO plenary session. ASCO is the biggest American oncology association. And there he presented data from a randomized control trial. But if you want to investigate the use of a digital care pathway in a hospital, actually you have to do a cluster randomized trial. That means you cannot in the same center randomize between digital follow-up and control. Actually, that's not the way to go. It's very difficult to do that with the same team. So what you have to do is a cluster randomized trial. That means you compare, like in this case, 25 centers that use digital PROMS and then 25 centers that don't use digital PROMS. So you compare centers and not within center. That's called a cluster randomized trial. And that's exactly what Ethan Bash has set up in the States. Actually, are 52 practices. Patients with metastatic cancer, so not only lung cancer here, but all different types of cancer, but there were lots of lung cancer involved, but also others. And patients receiving systemic therapy, so it's patients that having lots of chemo and sometimes IO, randomized to either no digital follow-up or digital follow-up. And then the outcomes that they are collecting are survival, and then physical functioning of the patient, symptom control, quality of life, and the appreciation of the patient and the team of the system. Survival is not published yet or not disclosed yet. Maybe will be at ASCO within a few weeks. But what he did show was the impact of the digital care pathway on physical function of a patient. And you see in orange, the top line is patients that are digitally follow up, and you see that their physical functioning is significantly better than the usual care arm along the whole pathway for 1 year. The same on symptom control. So there's a better symptom control in digitally follow up than in the usual care. And also the same again for patients' health-related quality of life is at each time point significantly better with the digitally reporting or following. A little word on the patient adherence. I mentioned in our system more than 90% compliance with filling in the questionnaires every week. In this trial, it was also weekly questionnaires, and you see they have the same figures. There's a 91.5 average of weekly reporting digitally by the patient, so very high. And again, the importance of feedback loops, feedback to the patients cannot be stressed enough. And then the first time we saw some data on what did the patient themselves thought of the system. And you see here for different items, blue is that they are okay with it, and red is that they are not okay with it, and green also. But for example, the majority of the patients found that the questions were easy to understand, that the system was easy to use, and that the questions were relevant. They also found that it improved discussions with the doctor or the nurse. And maybe most important, at the bottom line, the huge majority would recommend the system of digitally follow-up to others. Like 90% would recommend it to fellow patients. That's what the patients thought of it. They asked the same kind of questions to the nurses. It's less pronounced, but it's the same tendency. Blue again is a positive attitude. So most nurses found the information helpful for the documentation in their electronic health record. It improved discussions with patients, for example, and it improved efficiency of working. So in the beginning, it's a little bit, there's something, they changed their way of working, but once they have established a new workflow, quite often they gain time rather than lose time. And then again, a little majority would recommend the system to other clinics. So less pronounced than the patient themselves, but still a positive attitude generally in the nurses. I mentioned the trial I just discussed as a PRO-TECT trial, different cancer types, but they published a little bit of data on the lung cancer subgroup. There were 118 lung cancer patients in it. And then you see here, once again, because, I mentioned we are sometimes afraid of the compliance of our lung cancer patients who are all of older age often. But again, also specifically for lung cancer patients on the right, very high completion rates above 90% for the weekly follow-up. Again, confirming that from previous trials. So how to start now if you want to do this? Well, I discussed lots of things. You have ERTC questionnaires, you have the PRO-TECT AE, you have the ICHM data set, you have case mix variables. So you can think big, but if you want to start, I guess you rather start small and move on and learn fast and then adapt during the process. We've changed many times the process since we started, and we still do evaluations and try to adapt sometimes if necessary, because also, for example, treatments are changing. just do it. You can discuss about it for years, but once you have to jump. So if you want to go and just do it. Prepare yourself, but go for it. And the most important, or the most important difficulty actually is the change management. I know there are lots of practical issues, but they can be solved. But the difficult thing is that you have to change a way of working that you had for many years, because most of us, you work in a hospital, you are used to work on a given way for many years with a given team, and then all of a sudden, you have to change that a bit. It's not just like, okay, I go with this software and I use digital prompts. You have to decide what you will do with it. You will have to use it. You will have to create feedback to the patient. So the change is often the most difficult thing. And I just want to enter some incentives, because we are really convinced that there are lots of data, scientific data now, that support the use of digital prompts. But what is also interesting, when you use, for example, the Untitled Lung Cancer data set, you collect lots of data. And when you have those data, you can create very nice dashboards in which you can see your whole cancer population. You can see the smoking habits on population level, the age distribution, the sex distribution. You can see how many patients have weight loss. What we also have very easily is, for example, at the bottom right, how many patients have a KRAS mutation in your hospital, how many have a MET amplification. This is, for example, very useful if you do clinical trials and you always get those same questions. How many patients do you have from that type of cancer, that mutation, and so forth and so on? Well, if you collect it, you have the data there. Also on quality issues, for example, how did you establish a diagnosis? This is in the middle of the slide, the method of diagnosis. I can easily see the majority has a biopsy, and this is how it should be. But so now we can monitor that, and we can do it for every year. We can filter on tumor type, we can filter on age, you can filter on year of diagnosis. Very interesting data. And you can also create dashboards of your PROMS. This is what you see here. So you can see the number of patients that has lots of problems with vomiting, with pain, with anxiety, and every symptom that you record, you can actually put in a dashboard. And then finally, and this is really the end then, I mentioned in the beginning, we also want to compare our outcomes to colleagues. This is easily said, but not that easily done. But during the past year, we worked together very hard with our colleagues from Zolhenk, as another Belgian hospital. So we decided that we will use the same data set, so the Untitled Lung Cancer data set, the same questionnaires, so we use exactly the same questionnaires, and then we created dashboards exactly the same in both hospitals. Within a few weeks, we will do a first, what we call a mirror session. This is now an example of a dashboard from one hospital. It's an example, it's not on real data. They will have exactly the same. And then you have a really easy way to have a quick thorough comparison of your outcomes. So you can see the number of diagnoses, the age of patients, the treatment the patients get, educational level. You will be able to compare the quality of life because you use the same quality of life questionnaires. Importantly, we also added data on the quality of death. That means how many people during the last month of their life were in the hospital or were at an ICU unit or had to be at an emergency department. This is seen as a bad quality of that. You shouldn't be at those places at the end of life. That's the idea behind it. And we will now monitor that systematically and compare it with our colleagues. Just to say that it's not just about sending an email every week to patients with some questionnaires. We see the digital patient-reported outcomes as part of a holistic value-based healthcare approach with benchmarking and trying to improve by learning from each other. And by that, I'm coming to my last slide. So I'll be happy to answer some questions if you have a little bit of time. And I think we have, Rick.
Yes, we have. Professor Ling, I don't know if I'm pronounced it correct, asks have you used your rich outcome data, clinical and patient-reported outcomes, to operate any outcomes-based agreements for any of your systematic therapies or interventions?
So if I understand the question right, so correct me if I'm wrong, I think the question is meant, with all those data we have, do we use it to select a systemic therapy for a patient because we know based on our data that it will be the best. I guess that's the question. We haven't done yet, but we are doing now in the context of a research project. So on all those data, we are trying to develop AI algorithms that try to predict exactly which outcomes for which treatment. So in that research project, we try to predict mortality at 6 months, and we try to predict quality of life on treatment and side effects. So this is work in process. I've seen the first data a few weeks ago, and it's quite promising, especially for the survival prediction. But we have to validate that in bigger cohorts and so forth and so on, because we only have 200 patients. It's not that much for AI, but yes, we are planning to do so.
Professor Hamish also asked, like, do you visualize the PROMS scores for patients over time, and are patients able to see how they are doing compared to other patients with a similar stage of disease and treatment?
Yes, we do. So we can discuss for a given patient during a consultation visually if you want to. With the heat map, we can show, okay, this is how you did, and you come from there, and now it changed to that. But the first dashboard I saw, there you can compare with your fellow patients on the same treatment for the same stage of disease. But I mentioned that we're not 100% satisfied there. We want to change that a bit, but we can. But it's, yeah, we can do it better. I think we want to change it still a bit.
Yes, thank you. Marieke Parmentier asked, like, why do you choose AWEL? What were the determining criteria?
Yeah, that's a good question. Actually, to be honest, it is rather by coincidence, because I heard from a colleague that was working with AWEL in our hospital, and then I contact them. But then, okay, during that process, I learned to know that there are other companies also. But the focus of AWEL is really on the development of the digital care pathway, and they're not that much interested in like developing an app for a patient. You have lots of companies that try to develop apps with PROMS, but we always miss something in it, and it was quite rigid. It was not really tailored to our own care process. And yeah, we ended up with AWEL because it was quite flexible. We could have really good discussions. We could have our own input. So we ended up then with a pathway that's really tailored to the way how we work. And this can be different from hospital to hospital, while others are often more rigid and you cannot make too much changes. The feedback loops were very important for us, and it's not possible in many other systems. That's two. And then the third, during the time, so in the beginning, it was you had our electronic health records and a separate web-based platform for AWEL, but now the PROMs that are reported by the patients can be directly seen in our electronic health record from the patient. So it's implemented in it. So that's really an advantage that you don't have two systems. That was also important for us. So those are some reasons why we choose for AWEL.
Thanks. Luc de Keizer asks, do you need special patient consent to add patients to the PATH care pathway, or is this considered standard of care?
Well, that's a good question. We consider it standard of care, but we ask for consent. So in the digital system, the patient can't move on before he has given consent. Yeah.
And Kitty Kubo asked, in addition, with patients and onco nurses, did you also make a survey with GPs to get their impression of the care pathway?
No, we did not. And that's a good question. Question which I'm struggling with myself. So we don't know actually. Well, we have an individual feedback, but we don't know from the GPs as a group how to think about it. The problem there is a bit that we see lots of cancer patients every day, but if you look at the GPs, yeah, sometimes they have one cancer patient a year, lung cancer patient, or even no cancer patient in a few years. So it's very difficult for them to find someone who is a good, who can give good feedback on it. So we have some colleagues, but if they didn't see a lung cancer patient for them in a long time, they cannot really give good feedback. That's one. And then second thing is that it's not that easy. there are lots of GPs. So, okay, you address the representatives, who then share the information with their colleagues. We hope we organize some symposia to make public what we are doing, but you cannot reach all of them. You reach some of them representatives, but then you hope the rest gets involved. But it's not that easy. So it's a good question. We're struggling with it, and we don't have a systematic evaluation of how the GPs feel about it. But we'd love to have it.
Leo Dolsomol asks, was it heavy process to integrate AWL within your EHR systems?
I would say, Rick, maybe you should correct me if I'm wrong, but technically not that, but it's rather an issue of priority. I mean, we started with the new electronic health record, I think, in 2017. And as you can imagine in a hospital, the priority then is, okay, everything has to work. You have to be able to prescribe medication. You have to see the results. But PROMS was not high on the list of the hospital IT department to develop. So it's rather, we had to discuss with the IT department, try to convince them to help us and AWL. So I think technically not that difficult, but it's rather, availability of ICT staff in your hospital lots of the times.
Yeah, I think I agree as well. Then another question, and let me know, Ingel, if you need to go, but is the clinician able to see what interventions that the patient has had visualized in relation to the PROMS? So can they see what may have happened to cause the change in the scores?
Yeah, well, you can see in the electronic health record, where you also see the PROMS scores. If the onco coach gets in touch with the patient, there's a note in the electronic health record what has been done. If a patient is discussed at our weekly disciplinary team meetings, so we use those alerts there. We see if a patient has alerts, and an intervention has been decided. It is noted in the electronic health record. So, and that's the way you can see what has been done in as an action to a problem.
Yeah, and then another question, can you generate automatically official cancer registry data from your application to prevent double data entry? I don't think we can, but...
No, but it's actually the other way around. I mean, in our system, the dashboarding I showed, the baseline case mix, lots of those data are indeed actually the same data for the cancer registry, like TNM, stage, age, and so forth. So we use those data, we put those data in our electronic health record, and they use it to make a report to the official cancer registry. But the same input is used to create our background data actually for our care pathway, our case mix data.
All right. And then Bibian van Gorp asked, which professionals were enthusiastic and started building in AWL? Was it you, or was it first the nurses, or was it?
Okay, yeah. In this case, it was us, was a medical team. Yeah. Because the reason is we saw the data at the medical conferences on the potential benefit of PROMS, and then we started working on it. So it came from the doctors actually in our hospital.
Perfect. We don't have any. We just received another question. Maybe we can do 3 more if that's okay.
Yes, okay.
So in your experience, did you need support from ICT staff to create and adjust the care pathway?
In our hands, to create the care pathway, it was more, the IT staff from AWL then. So the adaptations at that time were made by AWL and not by the IT staff from the hospital, for example. But you can now, you can now build your own pathway from an start, but that is more for Rick, but you can build your own care pathway from an AWL library, and then you will need your own IT members, I guess, to help you.
Yeah. So we indeed designed the no-code platform where clinical teams and ICT teams design their own care pathways, and they don't need us anymore to build those. And then someone else asked, like, what would be the next step regarding the care pathway?
Yeah. Well, first of all, benchmarking process. So I mentioned it. We are in the middle of it. We are looking forward to our meeting in the next week with our colleagues to see how this works out. It has been done in the Netherlands, and there they showed that by benchmarking your outcomes, you increase the quality of care. So that will be the next step. Important for those kind of mirror sessions or benchmarking sessions is a trust between teams. Because in the past you sometimes saw them, you had the official reports, and then it was in the press they just put some lists, really meaning nothing at all, even giving bad information. But then you get the top 5 list from the best results, but really bad way of comparing. And now it's bottom up, physicians and their teams sitting together, discussing differences in outcomes and differences in care pathways. So that's one of the next steps. The other one is trying to expand to early stage lung cancer, a totally different setting without systemic therapy. So our radiotherapists and the surgeons started slowly on. Maybe important to say, there was a recent paper on digital prompts for lung cancer surgery patients, but also beneficial impact. So we are looking forward to have more patients in that pathway. And then, of course, we have to see treatments are changing also. So maybe it's possible. Now we use, for example, the same questionnaire for patients on immunotherapy, chemotherapy, targeted therapy. Maybe we will change this a bit in the future, a different questionnaire for every different treatment. That might be one of the next steps. And then another thing that I'm really interested in is, okay, we have shown beneficial impacts for the quality of life of patients, survival of patients, also on the use of healthcare resources, less ER department visits. So actually you have a system that could be, in my opinion, be reimbursed for. And so a few weeks ago, the first digital monitoring app in Belgium was reimbursed. It was not for cancer, it was for knee and hip surgery. But actually what we just showed, in my opinion, is also, could also be reimbursed. But okay, that's not my decision, of course. And then finally, the research part on the use of data to predict outcomes by using AI algorithms is also very exciting to look forward to.
Thank you. That was the last question of today. I thank you very much, Professor Demedts, for this very interesting presentation. We will send out the recording and the slides somewhere this week or early next week.
Okay, thank you. See you next time.
Have a nice day. Thank
Bye.
you.